Hello everyone. This is a case of adenomyosis and endometriosis. Patient is a 42-year-old para-2 living to with history of severe dysmenorrhea. In the intraoperative picture at the first look, we noted the left ovarian endometriotic cyst, completely obliterated pouch of Douglas with rectosigmoid adhesions, and a bulky congested uterus. The plan of action here was to mobilize rectosigmoid colon from lateral wall, ligate uterine arteries at the origin, to do ureterolysis, separate rectal adhesions with uterus, and then proceed with usual steps of total laparoscopic hysterectomy. First, we mobilized rectosigmoid colon as it gives good space for left ureterolysis. This is a look at the right adnexa. Here we can see both-sided round ligament being ligated and cut. The bigger picture is of the right side and the smaller window is of the left side. Dissection is done in the loose areolar tissue to identify hypogastric or internal iliac artery. Here we can look at the internal iliac artery. The safety point at this step was to visualize ureter and guard it. Ureter is seen in the medial peritoneal fold. Next, uterine arteries are further skeletonized. In this still, we can see both sided internal iliac arteries and uterine arteries. Uterine arteries are coagulated and cut at the origin. Next is dissection in the lateral pararectal space to do ureterolysis. The peritoneum is lifted, ureter is identified by its peristalsis, and with blunt and sharp dissection, ureterolysis is begun. With ureter in the view, right infundibulopelvic ligament is isolated, coagulated, and cut. Now with lifting up of the right adnexa, ureter is further separated from overlying adhesions. This step of lateralization of ureter is called ureterolysis, and this forms a very critical step in such cases. This is proceeded up until ureter is seen entering the ureteric tunnel. Now right adnexectomy is done. Both-sided ovaries and tubes are removed in this case. One can visualize both-sided ureterus in its entire course. Now dissection is proceeded in the medial pararectal space. Rectal fat marks the safety margin to guard rectum. This cut is advanced up until the pouch of Douglas. With some blunt dissection, a pocket of chocolate fluid is noted in POD. Similar dissection steps are carried out on the left side. After pushing the rectal fat medially and the right space is identified, right uterosacral ligament can be coagulated and cut. In this step of rectal adhesiolisis, mostly sharp dissection is done to open the Denon villus fascia. Here we can appreciate rectal probing is being done. This is done intermittently to appreciate the margins of the rectum to safely dissect rectum from uterus. Now we can appreciate opening of rectovaginal fascia. Again, rectal probing is done to confirm the right dissection. After this, the usual steps of laparoscopic hysterectomy is done, followed by opening up of the vaginal vault. A check cystoscopy shows clear urine efflux from both ureteric orifices. After removing the specimen's vault is sutured. This is the final picture and also the summary of the important steps involved in this case. Thank you for watching.